Hey everybody, I'm Dr. Deed Harrison. We are doing our 24th video for CBP nonprofit research. If you've been following these the last few weeks, you know that I've been talking about lumbar extension traction trials that either CBP nonprofit has done or our colleagues at Cairo University have done. This week we're going to wrap up the clinical trials. We're going to go through our final one. This one was published in 2012 in the journal Clinical Rehabilitation by our Cairo University colleagues, Professor Ibrahim Mustafa and Professor Aliyah Diab. Now this is a great project because in addition to looking at lumbar traction for hypo or loss of the lordosis, as in the previous trials, they're going to take a different look in terms of the population they're looking at. They're not just going to include chronic low back pain, they're going to include subjects that have a chronic radiculopathy due to a lumbosacral unilateral disc herniation. So without further ado, let's get through this project and let's find out what the implications are and the profound findings in this paper. Extension traction treatment for patients with discogenic lumbosacral radiculopathy, a randomized trial by Mustafa and Diab, Clinical Rehabilitation 2012. Now previously we've already talked about what normal is. Just to give you a quick background, we know that the lumbar lordosis should have 2/3 of its curvature down at the lower few segments. So L4 to S1 should have 2/3 of the curvature of the total lumbar spine. And that would be measured from either T12 to S1, or it could be measured from L1 to S1. The lumbar curve should be elliptical in its geometry. It should have more curve in the lower lumbar segments and less curve in the upper lumbar segments. The total curve, the way we measure it, L1 to L5, important in this project, the normal is about 40 degrees. We'll see where these patients start at. Also, the sacral base angle, the normal is 40 degrees. We'll see where these patients start at. Now, obviously, people that have an abnormal lumbar curvature, their discs are going to be more loaded than people that don't have a proper lumbar curvature. So when you take the curve out, especially in the lower lumbar spine, you change the load bearing from about 25% on the L5S1 disc, or 25% on the L5S1 facets, and you shift that load on to the lower lumbar spine discs. This can be part of the problem with lumbosacral radiculopathy, back pain, and disc herniation, okay? So in this particular paper, if we do a background check, what does the literature show? People that have sciatica and disc herniation, what is the classic finding on these people? Well, of interest, there's a project that was done earlier looking at correlations of lumbar lordosis and exam findings against subjects that have lumbosacral pain and radiculopathy. This project was published in 1991, and to my knowledge, it's one of the only ones that I could track down that looked at this particular feature. So this was done in the International Journal of Rehabilitation Research, 1991, volume 14, page 131 to 144. When they looked at subjects with lumbosacral radiculopathy from some type of space-occupying lesion like a disc herniation, what they identified was 5 key exam features that predicted or correlated to their pain and dysfunction. Number 1, sensory deficits of the legs. This was an indicator of poor long-term prognosis at long-term follow-up. So not only do you have pain, but you have true sensory disruption, indicating we have true nerve root compression or compromise. Tenderness in lumbar extension. So you go backwards into lumbar extension, might be good for you to do it in the long run, but it does hurt a little bit because of the pathology that you have going on. So that predicted a poor outcome. And then decreased repetitive trunk flexion capacity. Of interest, this is doing sit-ups. Now, I don't think sit-ups are a great thing for somebody to do, like classic sit-ups, when they have chronic low back pain and disc herniation. There's probably better things to do, core stability exercises, but this was one of their findings. We're going to get back to number 4. And then tightness of the hamstring muscles. Well, number 1, tightness of the hamstring muscles is likely a consequence of what's going on. Your back pain limits you from movement. Your lumbar disc herniation limits you from movement. So we've got a loss of flexibility in the system. Also, loss of the lumbar lordosis might indirectly cause its or cause decreased flexibility in the hamstring muscles. So when you look at this, number 4 actually becomes a predictive finding for me, short-term and long-term findings. I look at this and I go, well, no wonder they have back pain and disc herniation and sensory and motor problems in the leg. They've got loss of their lumbar curve. And this correlates to tightening of the hamstring muscles. Now, we already know that stretching the hamstring muscles will not change the lumbar curve. We did that last week. We've shown that stretching the leg muscles and simple exercises for the low back do not change the lumbar curve. The lumbar curve itself appears to be a primary problem in this patient pain population. However, we need a randomized trial to really confirm or refute whether or not restoration of the lumbar curve is actually able to achieve positive benefits for these types of patient populations. Okay, so here's our current study methods. 64 patients with unilateral lumbosacral radiculopathy due to an L5-S1 disc herniation. Lumbar lordosis less than 35 degrees. We're going to randomly assign these 64 subjects equally to one of 2 groups. Group 1, 32 subjects against infrared and hot packs. They're going to get this 3 times a week for 10 weeks or 30 visits. Now look, infrared and hot packs, classically chiropractors don't do a whole lot of that. However, there are clinical trials that show temporary benefits for people that have low back and leg pain. Okay, so we're testing a known procedure, and I say we as if I was there, but you get the idea. We're testing a known procedure against a new lumbar extension traction procedure for rehabilitation of the lumbar curve. So these subjects are going to lie prone or supine, they're going to get hot packs, and we're going to do this 3 times a week for 10 weeks, and we're going to add IR to it. Now group 2 gets the same things, IR, hot packs, but they also get our supine lumbar extension traction to restore the loss of the lumbar curve. Outcome measures, important. X-ray, lumbar curve, L1 to L5. Back and leg pain rating scale. Oswestry Disability Index. This is a big one. We want to look at their disability levels. And then flexion and extension intervertebral movements like was done in the 2012 JMPT project that they did. And then H-reflex latency and amplitude to look at a neurophysiological measurement looking at how compromised is the nervous system. In theory, it's excitability of the alpha motor neuron pool. However, because we're doing this externally, there's also some sensory implications when we do H-reflex. However, the theory is it's looking at excitability of the alpha motor neuron pool. Latency, meaning how long does the signal take to get down and back, and amplitude means its peak height and its low valley. So what is the sinusoidal wave pattern? Its height there, okay? And then we're going to stop care, follow these subjects for 6 months. Okay, now here's the method we're testing. We're looking at lumbar extension traction. This is the version of it that I designed in 1998. And then you'll see that they have a modification of this one. So we tie down the lower rib cage to stop the thoracic spine from extending. We tie down the mid to upper thighs so we can create pelvic flexion, which is going to reverse the problem with loss of the lumbar curve. And then we pull either in the middle or the lower lumbar spine to try to increase the lumbar curve. Okay, so number 1, start with a potential group of 100 subjects. You weed through them and you find out there's several that don't fit the inclusion criteria, so then what you're left with is 32 in each group. They're randomly allocated to a treatment group getting the traction, IR, and hot packs, or just the IR and hot packs. Treat them for 10 weeks, 30 visits, stop care, re-examine them the next visit. Okay, so on the re-examination date, there's no treatment whatsoever. And then we're going to stop care and follow them for an additional 6 months. You can see, by the way, the majority of subjects made it to the long-term follow-up, so there's an adequate sample size to look at proper statistical analysis of these subjects. Cut to the chase, the meat and potatoes of this. We already know how to do lumbar extension traction from the previous studies that I've gone through, so I don't want to go through the background. However, I do want to say this. You do have to be careful at first when you're dealing with this type of population. You cannot put extreme load on the lumbar traction because they do have radiculopathy. Remember the 1991 study I started with. These people are going to have some tenderness, so you have to work them through this. This is the purpose of hot packs and infrared. Now, as a chiropractor, I would do proper spinal adjusting on the side that was appropriate for the person. The side that elicited leg pain, I wouldn't adjust. I would adjust segments above or below the disc herniation as well. We might do some stretching. We might do some distraction to make it easier to get the person into the lumbar traction designed to restore the curve. Now, this project, we're just testing this one variable to see how effective it is. And you'll note that even though we're extending the spine and it might at first load that disc herniation, as I start to fulcrum off the lumbar facet joints, I start to unload the disc, and the theory is this will help out with disc herniation. I'm changing the load distribution back to where it should be. The discs in the low back are not designed to take 100% of the mechanical load. The facet joints are designed to take up to 25% in the lower lumbar spine. Okay, so let's look at the outcomes. Initially, in the study group, that's the group getting traction, the ARA L1 to L5 is 11 degrees. The control group is 11 degrees. So these subjects are matched. Now let's think about the normal. The normal is 40. These people have a 75% loss of their lumbar curve. That's why they hurt. You can't walk around with a 75% loss of your lumbar curve and not have consequences. You know, you look at this and you go, Deed, you get a little bit excited. Yeah, I'm kind of frustrated. People out there have this chronic back pain and leg pain. They don't know what to do. They go to all kinds of doctors and this and that test and this and that treatment. You know what? A lot of it starts with they lose their lumbar curve. Nobody did anything about it in the beginning, and then they end up down this chronic road of pain and suffering. It doesn't have to be that way. Get your spines checked early before you start to get this stuff, and let's do some preventative care. This is why I'm kind of passionate about this. When somebody comes in like this, you go, man, this is a challenging case. You'll see what happens. 10 weeks, 30 visits is only a drop in the bucket to what they need because they waited too damn long. Don't be one of those people. Don't go, oh, I don't want to go to a chiropractor. I don't believe in them. You know what? It's not a belief system. It is physics and mechanics. You don't get a choice to believe in it. You know, oh, I don't believe in the spine. Really? You don't believe your spine is important for health and disease. Then let's just be a slug, spineless, crawling on the ground. In this world, on this planet, your spine is there and it protects your body from a health and disease process. If you damage it, you're going to have problems. Back to this. Control subjects and treatment subjects, 10 weeks later, 30 visits. Okay? Now we're up to 19 to 20 degrees. Let's just round it up. 20, 19.7. That's a 9-degree increase in the lumbar lordosis in my study group. This one, the controls, they're 11.9. Come on, half a degree. That's no change. Infrared and hot packs does nothing for the lumbar curve, but extension traction increased the curve 9 degrees in this project. Now, if you remember 3 studies ago, way in the back, so it would have been project 20 or 21, we looked at the trial that I did in the year 2002. I identified with my team, we identified 36 visits was able to increase the lumbar curve 11 degrees, 36 visits. This paper is doing 20% less treatments, and of interest, they get about 20% less curve correction. They got 9 degrees, I got 11. Do you see a theme here? Traction works. It is important to restore the lumbar curve, but it's got to be extension traction, not distraction or flexion traction. So back to this. Control subjects, no change. Okay, now let's look at 10-week outcomes in pain and disability. The back pain goes 6.2 in the treatment group, 5.9 in the control. That's chronic moderate intensity, almost at severe, 1 point away from severe back pain. Down to 2.3 in the study group, 3.5 in the control group. There's a statistically significant difference. We know traction is doing something. However, IR and hot packs also did something. Look at the leg pain. About 50% better in the leg pain in the traction group. About a third better in the leg pain in the control group. So we're seeing, hey, we are seeing a positive benefit of the traction. Oswestry disability, 32. These subjects have moderate disability. 32 goes down to 20. That's about a third improvement in disability in the traction group. The control group goes to 24. Now they are improved, not as much. These subjects are improved by about 25%, and there is a statistically significant difference. Now, both groups are better at 10 weeks. That's because they got 30 visits of care. The traction group is a little bit better. Let's see what happens when we stop care. You stop care, follow for 6 months. This is the important part. What does it do for somebody after they're done with care? 32 went to 20, goes to 23. That's pretty good, mostly maintained. Of interest, the study group is now coming back to where the control group was after treatment, but now we're talking long-term follow-up. Look at what happens to the control subjects. They almost go exactly to where they were pre-study. In other words, it didn't have a long-term effect, but the traction is showing a long-term effect. We are seeing an improvement at 6 months still in the traction group that got lumbar extension traction. We believe that this is due to restoration in the lumbar lordosis. Now of interest, they still only have about 50% of the lumbar curve they should have. So if we look, why do you think they're still having back pain and disability in the group that got traction? Now we know they're better than the group that didn't get traction, but they're still not totally better. 30 visits was not enough. Why? Well, it's not enough to get the lumbar curve back to normal values. You know what? What needs to be done is patients need to continue with care, and they need to get as close to normal as possible. And the theory is, and our belief system is, this is what will get them out of their long-standing pain and disability. Now, obviously, that needs to be studied in a second randomized trial, looking at what happens when we continue to do care in these people. But come on, it's pretty damn obvious. If you get 50% better in your lumbar curve, and it improves your back and leg pain by 30% to 50%, then you got to keep going. You don't just stop. You don't go, oh, you know what? I drank a half a glass of water today. I'm fine. I'm not thirsty anymore. You know what? No, you didn't. You need to drink the whole glass. You need to get all the way hydrated. There are benefits for this. So keep going. If you're a patient out there, don't stop. We stop here in this project because it's a randomized trial. That's part of the study design. So people signed informed consent and they stop, and we see what we did. Okay? Now, hopefully you understand the back and leg pain outcomes related to the lumbar curve. Traction restores the lumbar curve. Of interest, now we're looking at the neurophysiological outcomes. This part is potentially the most exciting part of it from the clinician's point of view, and also should be from the patient's point of view. Is your nervous system working better by doing things that restore the alignment of your lumbar curve? Let's look. H reflex latency, 32, 33, both groups are matched. 10 weeks, we drop down to 29 in the treatment group, 31 in the control group. That's a statistically significant difference. What this is the time or the speed of transmission. So you might go, well, that's not that big of a deal. Yeah, it is. That's a huge change when you're looking at latency with evoked potentials or H reflex latencies. The amplitude, 3.1 to 4.1. That's a third bigger with the latency. That means we got a really nice signal with this. Look at the control subjects. The control subjects stayed the same. Their amplitude stays the same. In other words, the control subjects, even though they feel better, their pain's a bit improved, their nervous system is not working right. Still, it's screwed up. Just because you feel better taking some kind of medication or doing some kind of treatment does not mean your neurophysiology is better. This is what chiropractors have been trying to teach patients for years. Patients don't always get it. You have to see things like this. You go, wow, the traction, we restored the alignment of the spine. That takes pressure off the nervous system. It now functions better. As a result, you feel better as a result of this. However, you don't realize the profound effects. It's not just feeling better, it's functional improvements. If your nervous system is firing faster with a greater amplitude, then you're able to do things easier without challenges. You're able to walk. You're able to handle obstacles. Your nerves can tell your muscles what to do, and it stops you from slipping and falling and injuring yourselves. Now, these types of things weren't studied, but these are the absolute direct and indirect implications of this. If your nervous system works better, your body works better, okay? The control subjects didn't see any of that change in nerve reflexes, even though they felt a little bit better. The subjects that got traction, they're the ones that are getting the improvement in neurophysiology. This is a huge deal. You can see that I'm trying to explain it so you guys get it out there. Chiropractors, PTs, MDs, and patients listening to this is a big deal. Now, 6 months later, look, the study group getting the traction still improved in their neurophysiology. Control subjects, not so much. Okay? Same goes for the amplitude. That was the latency. This is the amplitude. Moral of the story is this. Look, I'm going to read this to you for a minute, so just follow along. Neurophysiologically, the significant and persistent changes in the H reflex parameters, that means the latency, decrease in time means it's working faster, your nerves fire faster, an increase in H reflex amplitude, that means the signal intensity is stronger, that's good. In the traction group, compared with the control group, could indicate that a normal lumbar curve is essential for normal nerve function. Restoring the normal mechanics of the nervous system and decreasing the abnormal stress and strain on neural elements are the likely explanation for the significant improvement in the H reflex parameters in the traction study group. This concept is supported by me. They are referencing a paper that my colleagues and I did in 1999 in JMPT on spinal cord biomechanics, who showed how loss of the sagittal curves alters the mechanical properties of the spinal cord nerve roots that may change the firing patterns of the involved neurons. Stop. The structure of your spine dictates the function of your nervous system via stress or loads placed on the tissue. If you don't improve your lumbar curvature, you do not take the mechanical load off the lumbosacral nerve roots. Your lumbosacral nerve roots will be under tension when you lose your curve. Then I put a disc herniation in it. It's a shear load in mechanics of materials. It's called a transverse load. So you stretch a bungee cord and then you push on it. It's got high pressures. That's not a good thing. That's why people have back and leg pain. That's why they have sensory and motor problems in the legs. It's because of the mechanical pressures on the nerves. Changing the lumbar curve alleviates that and people respond. Okay, now this is the flexion extension kinematic data. L1, L2 is the level. T stands for translation displacements in the sagittal plane. R stands for rotation displacements in the sagittal plane. I'm not going to go through this other than to tell you it's just like what was found by these researchers in the 2012 JMPT paper. They found restoring the lumbar curve improves the flexion and extension kinematics on in-range flexion extension films. Your rotations are better, your translations are better because of restoring the lumbar curve. The control group did not get those changes. Therefore, we can conclude the structure of your spine dictates the function of your spine under flexion and extension kinematics. There's statistically significant differences. So patients, if you're watching this, you see this as, I can't move right, I'm limited, I'm stiff, I have lack of mobility. Well, that lack of mobility is due to your loss of your lumbar curve. You cannot move right if you don't have a nice defined deep lumbar curve. It's how we walk. Human beings need to have a lumbar lordosis. If you lose it, mechanically, you're going to have to create more effort to create the same amount of mobility, and then you break down. You start to get stiff, sore, and spastic, and you don't move right. Traction restores that movement pattern, and we identified it in this particular project. An example of the measurement, L1 to L5, an example of, disc damage down at the L5S1 disc. Look, part of the reason these people may not get totally better either is because they got damage to their lumbosacral disc. Look at that disc. That's the disc space between L5S1. Look at the disc between L4, L5, and L3, L4. Those are proper disc space. How long do you think that problem's been there? Do you think it started yesterday, 2 days ago, 10 days ago? No, it probably started 10 to 20 years ago. The person realized they had some kind of back problem, but they either A, didn't seek care, or B, they didn't get the right type of care, and then bang, now 20 years later, they got a disc herniation, they got major damage, they got loss of their lumbar curve, and they expect it to be a quick fix. It ain't a quick fix. Even surgery, you go in there and you do a disc removal. So you do a non-invasive, they call it minimally invasive disc resection. So they go in there sometimes with a microscope or laser surgery, take out a piece of the disc, either fuse it or don't fuse it, and then now you remove the pressure on the nerve, but have you restored the mechanics to the spine? No. You still have loss of the curve. That disc is still damaged, right? You've got to work to restore the alignment of your spine. You've got to keep it there. You only get one spine. Do things to keep it healthy, right? Don't wait so long. I mean, we see these people that come in these offices and in these trials, and we go, geez, why'd you wait 20 years? And sometimes it's not their fault. They went somewhere, but they didn't get the right type of care. Well, now you know extension traction is required to restore the lumbar curve when you have chronic loss of your lumbar curve, with or without leg pain, with or without back pain. That's what this particular project found. Clinical message at the end. Lumbar extension traction is beneficial in restoring the lumbar curve. Yep. Restoring lumbar lordosis seems to be effective in patients who have lumbosacral radiculopathy with respect to their pain, mechanical movement, clinical status, and functional status outcomes. That's all the disability, the pain questionnaire, and the neurophysiology, as well as the flexion extension movements. Follow-up measurements at 6 months revealed stable improvements in all measured variables in the group that got the traction. Okay, now this is our 4th clinical trial. We have one non-randomized and 3 randomized trials on this. No longer is this a belief. Again, this is extension traction designed to restore the lumbar curve. This is not flexion traction. This is restoration of the lumbar lordosis with extension traction. This is not stretching on the long axis. This is not hanging upside down on a backswing. Those things temporarily improve back and leg pain, but they actually take out the lumbar curve. They don't put it in. You got to have a proper lumbar curve for proper improvement in mechanics and function, pain and disability. All right. I know I get excited when I do that, but you know what? If you don't have a passion and a purpose for something, then you probably shouldn't be doing this anyway. So hopefully you appreciate this. I'm not an angry person. I get a couple little comments here and there. People go, wow, he's really angry. I'm not angry. I'm passionate about this, and I'm really, really frustrated that patients aren't getting the right type of care. That's part of the reason we put this out there. The other thing is we need more doctors out there doing this. If doctors aren't doing this type of work, patients have nowhere to go. And then lastly, consider supporting our nonprofit research foundation, where we look at these types of projects. We try to improve patient health care via corrective chiropractic. All right, until next week, thank you very much for your time and attention. I'm Dr. Deed Harrison. If you like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy to use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP Nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up.